Our next speaker is Dr. Tom DeLaney, who is no stranger, I think, to this group. As you saw, he has participated in previous Chordoma Foundation meetings. Tom is a graduate of Harvard Medical School, an undergraduate, and then spent 6 years at the NCI as a senior investigator. He then went back to Massachusetts General Hospital, and he's been there ever since. He's a medical director of their Proton Therapy Center and a co-director for the Sarcoma and Connective Tissue Oncology group. He is extremely active in sarcomas nationwide. You can see from his biography that he is a very accomplished individual with a leader in his field, demonstrated by him being an executive board member for the Connective Tissue Oncology Society and a participant in the National Comprehensive Cancer Network Soft Tissue Sarcoma Guideline Group. I'm happy to say that he's here today to give us some advances in the treatment of chordomas, and I'm proud that he's a friend of mine and I can learn from him as well. So thanks so much for coming, Tom.
Thank you, Ivy. Thank you, Dr. Yuzemski, for inviting me to speak. Before I proceed with my slides, I think the first thing I want to emphasize for patients and families is that we are curing a significant proportion of patients. And it's in part related to the advances in surgery and to the advances in radiation therapy. Most of us who treat this tumor specialize in this tumor. As Dr. Sim mentioned, I participate in this sacral tumor study group. I am a radiation oncologist. I only treat tumors of muscle and bone, and hence I spend as much time with my orthopedic oncology colleagues as I do with my radiation oncology colleagues. One of the, I think, my most important points is that the first time a patient is treated is the best time, and perhaps the only time we have an opportunity to cure patients. And because of that, I cannot emphasize enough how important it is to seek care at a center of excellence. Chordomas are very rare. Many physicians have never seen one. Patients, as Dr. Sim mentioned, will often come in with a misdiagnosis or following an inappropriate initial procedure, which unfortunately can compromise cure. Because these are slow-growing tumors, what is the one silver lining of that is that it gives patients potentially the opportunity to seek information through the Chordoma Foundation, for example, who are now providing resources for patients to help at least direct them to institutions that are interested and have expertise in managing these tumors. And I think that's if there's any point that I would have you take away, I think that may be the most important point. So as Dr. Sim had mentioned, just a couple of comments about chordomas, slow-growing. They arise from what's called the notochord, which is the precursor to the spine. The rarity is emphasized here, 300 cases per year in the United States. In contrast, the 4 common cancers, colorectal, prostate, lung, and breast, there are between about 150 and 225,000 cases of each of those per year. It's about 10% of the primary bone tumors. There are about 4,000 primary bone tumors per year in the United States. The median age of presentation is about 60, but they can present in children and teens, as in Josh's case, especially in the skull base location. And the breakdown, as Dr. Sim mentioned, they can arise anywhere along the spinal axis, with the most common being at the base of the spine, but as well at the top of the spine, the skull base, and the spine cranial junction, and 15% what we refer to as the mobile spine, the cervical, thoracic, and lumbar spine. Now, this is just what they look like under the microscope, and you may see when you talk to your physicians that you may have a particular kind of chordoma. There are 4 recognized histologic types. The most common is conventional, and it doesn't have any what are called chondroid or cartilaginous elements. In the skull base, they can have cartilaginous elements, and about a third of the ones in the skull base are chondroid. This is a particularly nasty form called a dedifferentiated. It has a spindle cell component, and it acts like what we call a high-grade sarcoma or mesenchymal tumor. And then in recent years, there's been identified what's called a poorly differentiated chordoma, which occurs in young patients. It doesn't have these characteristic phyzoliferous, and phyzoliferous means foamy in Greek, but it is chemo responsive, and that's been an important advance in recent years. So as I mentioned, they are slow growing. For sacral tumors, it's about a 30% risk of metastases, and the risk appears to be related to the size and the histologic subtype, but also it, as Dr. Sim had mentioned, appears to be higher if the patient has a local recurrence. Unfortunately, the prognosis for many patients with metastases remains poor, although the tumors may be slow growing. There's often inexorable growth. Local control of the primary tumor can be a major challenge. Surgical resection is most commonly an important component of treatment. Nevertheless, local failures can be frequent and problematic. En bloc resections are favored in the spine, or whenever the spine and the sacrum, whenever they can be performed. Nevertheless, at some locations, particularly the upper sacrum and in some of the lumbar tumors, if they're large, the neurologic morbidity can be significant. And I think that's one of the challenges the physicians who manage these patients confront is how to balance the morbidity and the impact on quality of life with the attempt to eradicate the tumor. One point that I would also emphasize is that successful salvage treatment for patients who have a local recurrence is rare, and again just emphasizes the importance of the most appropriate and well thought out treatment from the start. As I mentioned, I work in a group of physicians who are interested in these tumors. We have a Chordoma center, and we try to have patients evaluated in a multidisciplinary fashion by all of the specialties at the time of presentation and discuss what we think is going to provide the optimal oncologic outcome as well as quality of life outcome. And we rely extensively on our colleagues for their input in terms of how to optimize the care and the quality of life for the patient. High-dose adjuvant radiation improves local tumor control, and I think this has become apparent in recent years. In the past, when lower radiation doses were used, it was just not enough to control the tumor, and it was often unsuccessful. So with conventional radiation therapy with doses of less than 60 gray, or that also means 6,000 rads, with the surgical techniques at that time from the 1990s, the early part of the 21st century, and radiation doses less than 60 gray, you would see high rates of local recurrence. A series from the early 1991 at Washington University, all 21 patients they treated had a local recurrence. As Dr. Sim had mentioned, the report from a very significant report from Mayo Clinic, the 54% local control rate at 10 years. Nevertheless, almost half of patients were still having a local recurrence. And Joe Schwab reported from a series from Memorial Hospital that 40% of their patients, and that was a non-actuarial rate, had local failures. And one of the ways that were chosen, initially the only way to elevate radiation dose was with protons, and these are charged particles, and they have a defined range in tissue related to the energy, so you can control how far they go in the patient based upon the energy imparted to them from the accelerator. And they have a deposition of a dose in what's referred to as a Bragg peak, and I'll show what that looks like. But at the end of the range of the protons, they deposit their energy, and there's no dose delivered beyond that point, so that spares the normal tissue beyond the range of the Bragg peak. And you can shift these Bragg peaks towards the surface to treat the tumors. I'll show you how you do that. And this contrasts with X-rays that continue to deposit dose beyond the target in tissue. And the sort of bottom line is that protons reduce the total body radiation dose by about 50 to 60%. So there's no advantage to radiating normal tissue, so it's a way of reducing the normal tissue dose and allows you to escalate the radiation dose and improve the local control of the tumor. And this just shows what Bragg peaks look like at different energies from 69 to 230 million electron volts. And these protons, for example, 69 million electron volts will go 5 centimeters. The current generation of cyclotrons and synchrotrons will allow you to accelerate the particles up to about 35 centimeters, allows you to treat the majority of patients. These Bragg peaks are too narrow to treat a tumor. They're only 2 to 3 millimeters in width. And what you end up doing is using it's called a range modulator. It's just a wheel that spins with different thickness, rims of material in it, and it just sweeps the Bragg peak through the tumor. And then you shape the radiation fields traditionally with what's called passively scattered proton therapy with customized brass apertures that are milled by computer-controlled milling machines, as well as you shape the distal edge of the proton beam with what are called range compensators to compensate for the differences in radiologic density in the patient between air, soft tissue, muscle, and bone. And essentially what you end up having is kind of a complicated set of beam-modifying equipment that allows you to shape the radiation dose around the tumor. And what this gives you is a radiation dose distribution if you have a tumor from, say, 15 to 25 centimeters of the no exit dose beyond the distal edge of the tumor. In contrast, X-rays have a higher radiation dose both beyond the tumor and in front of the tumor. Currently, though, we're taking advantage of the charge on the proton, the positive charge, and using magnets to steer a thin beam of protons and raster it across the deep edge of the tumor. Then you reduce the energy and treat the next level, the next layer, until you can fully contour the radiation dose around the tumor with no exit dose and less entrance dose than you have with passively scattered protons that have higher entrance dose because of the beam modifying elements in front of the beam. And what this ends up giving you is this is comparing what's called intensity modulated protons, which is scanning protons using the magnet, but also varying the fluence of the proton beam across the field to shape the dose distribution, in this case for a paravertebral sarcoma, with the absence of any exit dose to the lung and hearts. And this compares to the most technologically advanced X-ray technology called intensity modulated X-ray therapy, which gives a very similar dose distribution around the tumor, but you have this exit dose to the lungs and the heart. And this exit dose has no advantage for the patient. It can only produce toxicity. And so the potential advantage for protons is the marked reduction in total body dose by up to about 60%. And this improved dose distributions compared to photons or X-rays when they were delivered in the past with what the standard radiation technique at that time was. And this allowed dose escalation with acceptable normal tissue side effects for skull-based sarcomas, tumors in the eye, and for prostate cancers. And currently, with the scanning proton beam, it can also allow you to potentially, when the protons, those scanned protons stop in the patient, they have somewhat higher energy transfer at the end of their range. If you paint all those spots inside the tumor, you can differentially load the biologic effect into the tumor compared to normal tissue. So that's just being explored in current grant efforts. Nevertheless, protons are about 3 times more expensive than X-rays, and because of the concerns about cost, there currently are studies ongoing to see if the difference in radiation dose distribution translates into demonstrable clinical benefits. And there are randomized phase 3 studies currently underway comparing X-rays to protons for locally advanced lung cancer, breast cancer, prostate cancer, and the NRG Oncology Cooperative Oncology Group is currently planning studies for low-grade brain tumors, head and neck cancer, oropharyngeal cancer, esophageal cancer, and liver tumors. And I think it's primarily driven by the cost. I think if the cost were lower, frankly, a larger proportion of patients would be treated with protons. This technology in 2002, there were just 2 centers in the United States. In 2016, there are now 22 centers in operation and another 13 under construction, 39 operating outside the United States. You may also, as you look at the literature on chordomas, come across carbon ion. Carbon ion is 12 times heavier than a proton. It produces denser DNA damage than a proton. And there's some interesting results for chordomas and sarcomas with carbon ion. So there are additionally several carbon ion facilities. There are 2 currently in 2002, and there are now 2016 9 facilities in operation, and there are some studies currently ongoing to compare protons to carbon. Looking to the future, there are now single-room facilities available. We've added a single-room proton facility to in our hospital. It fits in 2 linear accelerator vaults, so it fits into a conventional radiation oncology suite, and the cost is about $30 million, which is about a fifth of what a conventional charged particle facility costs. So this technology is likely going to be more widely used. So I'm going to move on now to just advances in chordoma treatment and talk about some of the results. The first experience I wanted to discuss is the use of high-dose proton-based radiation with or without surgery in the management of primary or recurrent spine chordomas. And we had looked at our patients treated at Massachusetts General Hospital, 126 patients, 127 tumors who had localized chordomas in the thoracic, lumbar, or sacrococcygeal spine, treated between 1982 and 2011. And the patients had high-dose protons with or without surgery. And this just shows the local control of the tumor, whether patients were treated at the time of primary presentation, so initial treatment compared to recurrent treatment. And at 10 years, the local control was 52% for primary treatment, only 42% for patients who were treated at the time of a recurrence. And when you look at 5 years, 68% of the patients treated for primary tumors were free of local recurrence, compared to only 49% for patients treated at the time of recurrence after prior surgery. The extent of surgery is important when we compared en bloc, which is taking out the tumor in one piece, compared to intralesional resection, where the tumor is removed in pieces. By 10 years, only 35% of the patients who had tumors taken out in pieces were still free of local recurrence, compared to 72% who had a tumor resected in a single piece. We found that an increasing number of surgical procedures before the definitive surgical procedure led to a higher rate of local recurrences, usually related to tumor spillage at the time of an attempt to partially remove tumor. And these data are perhaps the most compelling. Because of this problem of what we call seeding of tumor, you're often operating in close proximity to the margin of the tumor, and tumor cells can be spilled at the time of surgery and then implant into the wound. And it's hard to address that with postoperative radiation. We found that by giving a component of preoperative radiation to essentially sterilize the tumor before surgery, we were having much better local control results. And when we compared for patients treated at the time of primary presentation, whether they had a component of preoperative radiation at 5 years, their local control was 85%, compared to only 56% if all of their radiation was delivered as postoperative radiation. Even more interesting was a group of 28 patients who had primary tumors who had what we feel is perhaps the most appropriate management strategy for patients who have tumors that are felt to be resectable with acceptable morbidity. These are patients who had a CT-directed core biopsy, preoperative radiation, en bloc resection, and then they had postoperative boost radiation. And we had no local failures in those 28 patients. And because of that, we've begun to do something I don't think most centers are currently willing to do, is to start reducing the radiation dose. We've reduced the total radiation dose from 70.2 gray to 68.4 gray 4 years ago. We had no local recurrences, and we're now down to, we've reduced the dose to 64.8 gray. I was talking to Dr. Peterson yesterday. We do have some patients who had received preoperative radiation of 50 gray who went on to have, did not receive postoperative radiation. Some had perioperative complications, some had delayed wound healing, and we have about a 50% rate of local recurrence in those patients. So it suggests that you do need a radiation dose that's above 60 gray, and will probably settle out at somewhere in the 64.8 gray range. Just to pause for a moment, what you're looking at here are the two older twins holding the most recent twins delivered in 2016 from a mom we had treated, and she said I could share these photos with the group. Characteristic in a number of ways. She had carried a incorrect diagnosis of neurofibromatosis. She had some neural lesions that were eroding bone, and ultimately one of these was partially taken out in the sacrum and found to be a coccygeal chordoma. And at that point we sort of questioned the prior diagnosis and documented that she also had a chordoma at L4, and she had a skull-based chordoma. And over the next 2 years she underwent preoperative radiation resection and postoperative radiation for the coccygeal chordoma. And when she was getting her post-op radiation for the coccygeal chordoma, we were also doing the pre-op radiation for the lumbar chordoma. She went on to have that resected, and then she had resection of the skull-based chordoma and post-operative radiation. She's now 6 years out from the last of her treatments. She has no evidence of disease. She ambulates normally. She's on no pain medication. Her coccygeal tumor was below the level of the S1 to S3 nerves that are responsible for bowel and bladder control. So she has normal continence, and she has delivered 2 sets of healthy twins. We did suggest that she have cesarean sections for delivery because of concern about the risk for a potential sacral fracture in the radiated sacrum with the delivery. But again, I think for patients and their families, we will often put patients through a year of treatment and recovery, and I think it's hard during that, and when you have the diagnosis, to focus on the fact that there is life beyond treatment. And I think this is extremely important, and it's important for us as well as physicians, because we're trying to get you there to cross the river of treatment to back to your life. This just illustrates my point about doing exclusively postoperative radiation. The bowel, after you take out the sacrum, will herniate into the radiation field, and here it's very difficult to exclude. So a component of preoperative radiation allows the radiation oncologist to better spare the bowel if a lot of the radiation has been delivered before the bowel falls into this field. Just to emphasize the fact that even for some quite difficult local presentations, we are managing to achieve local control of tumors with this paradigm of a combination of preoperative radiation for patients who we might anticipate might have wound healing problems because of, in this case, a massive tumor with significant subcutaneous involvement. We have used in some patients a lower radiation dose, followed by surgery and postoperative radiation, and this is sort of our standard dose. He remains locally controlled, but again, the size of the tumor, he has developed inguinal metastases. And then as I talk about the systemic treatment, there are probably at least a third of patients who have large tumors are going to develop metastatic disease, which our understanding of the biology is the micrometastases likely spread before any treatment was initiated. Again, as a patient who had a very large lumbar chordoma abutting the aorta here, received preoperative radiation followed by resection and something called a dural plaque, which is a way of delivering some radiation to the dura adjacent to the spinal cord. And he remains locally controlled, but again, had, based on the size of the tumor, has developed lung metastases. I think just a point here that a dural plaque alone is probably insufficient treatment. A woman who had a T12 chordoma And the dural plaque just treats the dura and doesn't treat any other part of the tumor bed. And she had a very difficult local recurrence, again, above and below the site of the tumor 17 months after surgery. This is kind of an interesting experience that we have reported and are getting additional experience with. This was the first report of 24 patients we had treated. My junior associate, Yenlin Chen, had written this up. It was reported in Spine in 2013. 24 patients who had mostly had conventional chordomas, and the majority of patients had tumors in the upper sacrum. And the reason we accumulated these patients is that these were patients who were neurologically intact at the time of presentation. And when you resect the upper sacral nerves, S1 to S3, you impair control of bladder and anal sphincter continence. Which can be, and as well as for men, erectile function can be a significant impact on quality of life. And so what we elected to do was then to treat these patients to a higher radiation dose than we would if they were undergoing surgery. So they were treated to a dose of 77.4 gray, which is an 8.5 week of radiation treatment. This is actually one patient who had a similar lesion, a high cervical chordoma, and she had declined surgery. And as I say, 77.4 gray was the total dose. This is just from the radiation oncologist. We just used intrathecal contrast here at the time of treatment planning to optimally define where the spinal cord was and to spare it. And this is a patient, my colleague Herman Soot, who was a pioneer in the use of proton radiation therapy and was one of the drivers in terms of building the Proton Center at Mass General. And he had treated this patient back in 1999. And he's now over 15 years out from treatment for a large sacral chordoma. And so of these patients we treated, their what we call local progression-free survival at 5 years was 80%, and a little bit lower when we projected out to 10 years, about 70%, which is a substantial win for these patients who declined not to undergo surgery. We had no spinal cord injuries. Unfortunately, I don't think there's any treatment that we do in medicine that doesn't have risk of toxicity, and we essentially are pushing right up against the tolerance of, in this case, the lumbosacral nerves. We had one patient who developed a sacral neuropathy. It was a lumbosacral nerve injury with foot weakness. One patient had new erectile dysfunction. When we were using passively scattered protons would have a higher skin dose. 3 of the patients had what we call fibrosis, just the soft tissues became firm. 4 patients had rectal bleeding, and some patients will now try to avoid this by putting in a spacer with a surgical procedure to displace the rectus sigmoid from the tumor prior to radiation therapy. And sacral insufficiency fractures are bone, you may not think about it, is a dynamic tissue which is always remodeling. And if the sacrum sacral strength is impaired in part by tumor, and then you add radiation, you're at risk for fractures. In this experience, these patients did not need any surgical correction, although in some patients who have this, they will need spine stabilization procedures. But this rate of sacral insufficiency fractures is not too dissimilar to what is found for patients who have sacral resection and radiation. In fact, for high sacral tumors, we have a higher rate of sacral insufficiency fractures. And one of our recent fellows recently updated this experience. It's just been accepted for publication with 40 patients now, and the 5-year local control was 85% again. But there can be local failures after 5 years. In this case, 2 additional local failures. So probably running about 70% projected currently at 10 years. And we're encouraged by this, but this also does emphasize the fact that if we can perhaps add additional systemic treatment to this definitive radiation modality in a number of other tumors, the addition of chemotherapy has improved the local control of tumor you see with radiation alone. that's something we're hoping in the future. I'll make a comment about that in a study we had recently done. Carbon ion therapy, large experience with carbon ion for unresected sacral chordomas, and their local control at 5 years, very comparable to ours. This is a little bit worrisome. It was published earlier this year, their 10-year local control of 52%. The one thing that is different that they've done is they have only treated essentially the tumor in about a centimeter total margin. I think this is probably inadequate for what we see as the patterns of spread for chordomas. The tumors can get into the ligaments that connect the sacrum to the back of the pelvis, the ischial spine, I call it sacrospinous ligaments, or into the muscles emanating from the sacrum, the piriformis, the gluteus musculature. So we've generally given at least 1.5 to 3 centimeter margins for the first 5,000 rads around these structures or around the tumor to include the sacrospinous ligaments, the piriformis musculature. And I was discussing this with the radiation oncology group at the Proton Center here at Mayo Clinic yesterday. But I think this is something that does need to be observed. Nevertheless, they appear to be able to do this with a low rate of high-grade nerve injuries. In fact, they majority of patients whom the injuries occurred on were at a higher radiation dose, and most patients are being treated with a lower radiation dose. So the majority of their patients have remained ambulatory. So as I mentioned, carbon, these are heavier particles. They may be less impacted by oxygen. They produce denser DNA damage. The radiation schedules are different. They tend to treat with a smaller number of larger fractions, and it's been a little bit hard to compare. Nevertheless, that carbon is probably 50% more expensive even than protons. So there are randomized studies currently in Germany for skull-based chordomas and sacrococcygeal chordomas comparing carbon and protons that will hopefully allow in a what we call give us level 1 evidence comparing the two modalities. As I currently look at them, I don't see a significant difference in the outcome. They look quite comparable to me. But again, it's not always clear how patients are selected for treatment. So I think this is the rigorous way to compare them. And this just shows that currently we have nearly completed a study of scanned beam protons for patients with sacral and spine tumors. We've accrued 55 of the planned 60 patients, and we're thinking in our next iteration to take advantage of the fact that the scan beam will allow you to selectively deliver higher doses to the gross tumor, and we'll start to increase the dose per day and shorten the overall treatment course for these patients. Although we had the capability to do this on the current study, we're trying to be rigorous and compare to our prior experience with passively scattered protons. We just wanted to change one variable. In this case, we went from passively scattered to scan beam, and the initial results are that the local control appears comparable, and there's less soft tissue fibrosis related to the scan beam. So I think the quality of life and functional outcomes should be better. Just a couple of moments about skull-based chordomas. As a disclosure, my colleague Norbert Liebsch treats these patients, so I'm not treating patients with skull-based chordomas, and so I'll make some remarks in kind of a generalist kind of way. So this is the top of the spine and a frequent site of chordomas, the clivus. This, again, as with most other chordomas, the surgery is a challenge. The deep localization of the chordomas in the middle of the skull, it makes surgical access to these tumors difficult. Again, I can't emphasize enough, it's important to have the surgery performed by an experienced surgeon. There are a number of approaches, including a lot of recent experience with what are called endoscopic endonasal approaches, where you come up in a less invasive way through the nose and into the skull base, and particularly for midline tumors, good visualization. As the tumors extend more laterally, you unfortunately have less visualization. In contrast to the lower part of the sacrum and the mobile spine, it's uncommon to achieve a complete resection, and most of the resections are they're almost always intralesional resections, and the recurrence rate, even after a complete resection, remains high. In the older days of less conformal radiation techniques, the radiation dose that you could deliver was limited by the adjacent brain, optic nerves, brainstem. And in that era, the radiation doses ranged between 5,000 and 6,000 rads, and the tumors recurred in 70 to 100% of the patients. And sort of even when one had modern imaging and radiation treatment techniques, but at a lower dose, 5,000 to 6,400 rads, only 23% of patients were free of progression of tumor at 5 years. So this emphasizes the importance of high radiation target doses. And currently, there are a number of ways to do that. Protons, and there are results from Mass General, from Loma Linda, from the Swiss Institute of Paul Scherrer, and then in Paris, of delivering high-dose radiation with protons, and the 5-year tumor control, 73%, but at 10 years, still only 54%, again, emphasizing the need for additional research for these tumors. Nevertheless, this is still better than the historical data where the local control was only 30 to 50% at 5 years and falling. A number of factors. Smaller tumors do better, in this case from Loma Linda, tumors less than 25 milliliters. They had no local failures. The ability to deliver the dose can be related to whether they have, in this case, brainstem compression. So you have the radiation tolerance of the brainstem is less than what you need to eradicate the tumor. So just the anatomic configuration of the tumor will affect the local control. And again, it's an area where there are critical cranial nerves, and there can be a risk to these nerves depending on a number of factors, including whether the tumor is compressing the brain, the number of prior surgeries, whether the patient has comorbidity, diabetes, hypertension. And for low-risk patients, the risk of significant side effects only 5%, but the high-risk group who have multiple other comorbidities can be above 10%. Particular patients who have radiation as a salvage after multiple failures after prior surgery. So recently, there are other radiation modalities, and I'm sure to patients and families, this is a bit dizzying, but it basically comes down to ways of delivering focused X-ray treatment to the tumor. Again, the difference, there's a slight biologic difference. Protons have a higher biologic effect, but we in fact compensate for that. So I think most of the difference is the fact that the conformal radiation modalities deliver more radiation to the rest of the brain, although these are often not that, the tumors often aren't that big, so you can often deliver significant radiation doses with these other specialized conformal techniques. And these include stereotactic radiosurgery or stereotactic radiotherapy, where the patient is rigidly immobilized and you target the tumor from multiple directions, something called a gamma knife, which refers to a device with multiple focused cobalt sources around the patient. LINAC radiosurgery or the cyber knife, it's just a linear accelerator, which is on a robotic arm, but it has the advantage of X-ray image guidance. And when one looks at the results with focused radiation treatment from the group in Heidelberg, they have about 50% local control at 5 years. Somewhat lower radiation dose given with larger fractions from Rob Foote here at the Mayo Clinic. Their local control was 32% at 5 years. The gamma knife radiosurgery, quite small tumors, encouraging rate of local control 63% at 5 years. This is a recent experience from the Toronto group using what's called image-guided. There's a CT scanner in the treatment room. They're delivering high radiation dose, and again, their local control about 65% at 5 years. Again, sort of comparable to what's achievable or been reported with protons. They did report 14% of the patients had radiation-associated injuries, and their series included patients treated with chondrosarcomas to a lower radiation dose, so the toxicity risk might be slightly higher in the chordoma cohort. Carbon ion appears very similar to what is reported with proton beam. Proton beam about 73% at 5 years, carbon ion 72% at 5 years. So these are among the best reports for skull-base chordomas with either protons or carbon ion. And as I mentioned, there's a study comparing protons and carbon for skull-base chordomas in Heidelberg, currently open. So I think the last few minutes I'll go on to some of the medical therapies for chordoma. A number of the slides I've gotten from Silvia Stacchiotti, who's a member of the Chordoma Foundation Medical Advisory Board and a colleague of mine from Milan. Medical therapy, unfortunately, continues to be suboptimal. When you look at chemotherapy, which tends to produce responses in tumors that are rapidly proliferating. When you look at the results with conventional chemotherapy for chordoma, it's the response rates are really quite low, which is similar to the response rates for other low-grade malignancies like chondrosarcomas. Some chordomas, in particular the dedifferentiated chordomas, may respond like sarcomas, and that chemotherapy can be an important component of the treatment for those patients. So the Chordoma Foundation supported an international consensus meeting several years ago. We've published a position paper in Lancet Oncology, and the bottom line from the chemotherapy point of view is no drugs are approved for the treatment of advanced chordoma, and I think that's been a major emphasis of research in the Chordoma Foundation, and Josh can discuss the research portfolio that's currently being supported. As I mentioned, the chemotherapy for chordoma, one study from University of Michigan, they have a 7% objective response rate. So when you read the literature, response rate refers to shrinkage of the tumor by more than 30%. So it's a measure of response, and there may have been some delay in progression of disease, but certainly much work to be done there. Increasing interest in what's referred to as targeted therapy. So targeted therapy relies on identifying signaling pathways in the tumor that are responsible for growth of the tumor. And chordomas express a growth factor receptor called platelet-derived growth factor receptor, which is driven by the platelet-derived growth factor. And the group in Milan, Silvia Stacchiotti, evaluated 44 patients with imatinib, one of the first of these targeted agents, also called Gleevec, and they reported 73% clinical benefit, which includes a complete response, the tumor disappears, a partial response, shrinks by a third, or stable disease for more than 6 months. And again, from the patient perspective, if the tumor stops growing, that's clinical benefit. That's what we're in the business for, is to stop these from growing. And they had mentioned that the median progression-free time was 32%. That meant that if 100 patients start treatment, 50 of them at 8 months have not progressed, and by a year, about 40% had not progressed, and nevertheless, only 16% were still on treatment at 18 months. So some benefit, looking for more benefit, and so. Again, the importance of basic research. There's evidence of either upstream or downstream activation of a signaling molecule, what's called the mTOR, mammalian target of rapamycin, which can be blocked by an inhibitor of the mammalian target rapamycin called sirolimus. And so they studied this in patients who had progressed on imatinib. They had 9 assessable patients. They had 1 partial response, 7 patients with stable disease, and one with progressive disease. So they did see the clinical benefit was they said 89%. So they currently have a study in progress with imatinib and everolimus, another one of these mTOR inhibitors. It also goes by the name of RAD001 if you look this up online. Some of the other targeted therapies, these are, again, what are called tyrosine kinase inhibitors. They're all block signaling pathways that are responsible for growth in these tumors. Suzanne George reported sunitinib. 4 patients had stable disease for at least 4 months. Sorafenib, 27 patients, 1 partial response, but the 73% of the patients had not progressed at 9 months, that's encouraging. Again, some significant risk with sorafenib in terms of generally hematologic or other toxicity. So the takeaway from the targeted agents, imatinib and sorafenib, are the medical therapies with the greatest evidence of anti-tumor activity, and they represent reasonable, what we refer to as palliative treatment options, so slow the tumor down, hopefully alleviate symptoms, in particular for whom local salvage treatment is not possible. I haven't commented much on local salvage treatment. There are local salvage treatment options, which for patients who haven't been radiated includes radiation with or without more surgery. There's some experience with large single fractions of radiation, although I think in my experience, as I've followed patients who have been treated for a recurrent chordoma after prior surgery, they continue to be at risk for recurrences even in close proximity to the area where they had their first recurrence. And this is at times a concern with some of these medical therapies, which can be quite costly. Access to these drugs varies widely among countries, and it poses a challenge for the patients and as well for the physicians who are managing them to try to get them these drugs. Another one of these targeted agents is called nilotinib. It's more potent than imatinib. Again, it blocks one of the tyrosine kinase inhibitors. My colleague Edwin Choi from Medical Oncology at Mass General, we collaborated on a phase 1 study where we established that you could deliver this dose, 200 milligrams, as an oral dose daily. Was tolerable in conjunction with definitive radiation therapy, and we treated 11 what we refer to as high-risk patients, either locally recurrent after prior surgery or unresected, and the study's completed accrual, and we're getting ready to analyze it as we get additional follow-up on the patients. Chordomas also express something called epidermal growth factor receptor, and a study of one of these growth factor receptor inhibitors, lapatinib, was recently published. 6 of the patients had a partial response, 7 with stable disease. So the clinical benefit rate was outlined as 22% in this patient group. Lastly, as I kind of lead into the next talk, Joe Schwab, one of my orthopedic oncology colleagues and spine surgeons, his wife's dad is a world-class immunologist, Soldano Ferroni, and has been working with Joe to study these tumors, and we found lymphocytic infiltration, so lymphocytes in the tumor. So presumably lymphocytes trying to fight the tumor in 84% of the tumors that were removed or studied at Mass General. But they had noted that the immune response requires processing of proteins expressed on the tumor to activate the immune system. So there was loss of some of this antigen processing machinery, and some of the additional antigens were abnormally expressed. And this, they felt, was consistent with the possibility that the infiltrating lymphocytes are trying to fight the tumor, but there are, in fact, suppressive mechanisms or inability to activate the immune response in these tumors that essentially facilitates the outgrowth of tumor cells which have escaped from immune recognition and destruction. But this is a potentially fruitful area for study. Many of you have heard of brachyury. It's a transcription, a family of, it's one of a family of transcription factors, and it is almost universally expressed in chordoma cells. And T cells that are activated against brachyury can destroy human cancer cells. And this MHC just means that you have to have the antigen processing machinery intact. And a vaccine based on a yeast which is expressing brachyury has been developed, and at the National Cancer Institute, Chris Heery had participated in a study, and 11 patients had chordomas, and the vaccine was given safely without adverse reactions. And it did, when they tested immune function in T cells, they did document immune response. One patient had a partial response, and 7 of the 10 other evaluable patients had stable disease for more than 5 months. This has led to a study which is currently ongoing, and it's at the National Cancer Institute, and they're planning to recruit 55 patients, and patients are randomized to vaccine administration or placebo administration. So placebo is non-active saline salt solution, and it's to try to see whether if you can induce an immune response, does it affect outcome? And the patients that they're recruiting are patients who have a locally advanced unresectable chordoma, so recurrent after prior surgery, or being treated with radiation for a tumor that couldn't be resected at the time of initial presentation. The patients start off with injection of vaccine once a week, and then they go on to get radiation, and then they have additional vaccine afterwards. And I've referred several patients to this study, and so this is ongoing. I think it's an important study. So in summary, we are able to achieve local control in a substantial proportion of patients with chordoma. I think there's no question it requires optimal surgery, and in many patients, radiation therapy. I think there may be patients, particularly those who have distal coccygeal chordomas, who might be treated with surgery alone with good margins. Although my colleague, Fran Hornacek, who's the head of orthopedic oncology surgery at Mass General, had a group of patients whom he operated on for chordomas, all who had negative margins. And there were 2 radiation oncologists at that point, my prior colleague, Ira Spiro, who was treating these patients with radiation therapy, and then Norbert Liebsch, who had thought that if the surgical margins were negative, that we could just observe the patients. And all of the patients who just had surgery alone ultimately went on to recur. Now, some recurred over 10 years later. So I think we're still trying to figure out how we can. I think there are patients who are locally controlled with surgery alone, and the question is just how to identify them. And we weigh the potential downside of radiation therapy, which can increase the rate of wound healing complications and the rate of insufficiency fractures, for example. We weigh those risks against the fact that if a patient has a local recurrence, they're very difficult to salvage. So I think that's something that, as part of the panel discussion this afternoon, we hope to have some more discussion about that. Protons reduce the total body radiation dose. That can only benefit the patient. I think the major concern in the past has been the cost of building a proton center, which for a large proton center can be in the range of $150 million, and the cost for protons is probably 3 times higher than X-rays, although I always emphasize that in many ways protons are a bargain. Linear accelerators that treat with X-rays, you're accelerating electrons, and for protons, you're accelerating protons. Protons are 1,800 times heavier than electrons, so we're lucky that protons aren't 1,800 times heavier. They're cheap. They're only 3 times more expensive than X-rays. But I think with most technologies, as they mature, cost comes down. As I say, these new single-room facilities are very sophisticated, look to be an option. And they, of course, are the treatment of choice currently for pediatric solid tumors because they reduce the total body radiation dose. Again, I cannot emphasize enough the importance of seeking care at centers with experience with the disease. The Chordoma Foundation has been a tremendous resource for patients. I can only applaud their efforts both in helping patients to manage the difficult decisions for their role in supporting both basic and clinical trial work. And again, I would encourage patients to take advantage of the resources that they offer to help you make the difficult treatment choices. The relative benefit of photons versus protons in adult patients, there are ongoing randomized trials. I think cost reduction is already occurring. Scanned beam allows you to do what's called intensity modulated protons, so you can differentially put more dose into the tumor compared to the elective field around the tumor, and you can also use it to optimize the biologic effect by putting the higher weighted what's called linear energy transfer, the higher energy portion of the protons in the tumor. Heavier charged particles, carbon ion, is being the role is being compared with protons in randomized controlled trials. Unfortunately, systemic therapies currently are not curative. A significant proportion of patients, particularly patients with large chordomas, large spine chordomas, or patients who have locally recurrent chordomas, are really only going to be candidates for systemic treatments. There are targeted agents available currently that they can be used for palliation. Unfortunately, they usually are not curative. Immune therapies, which have shown great promise in a number of diseases recently, are now being tested, and I think that's probably a good lead-in for the next talk. Thank you.
You showed the dosage for proton being lowered in 3 different periods. What is the reason for trying to lower it if you are successful with a higher rate, if it's not affecting any other part of the body?
It's a very good question. We know that total dose does improve the local control of tumors, and what I think we are trying to determine what is the optimal dose. I think the doses that we currently have been using, they're very close to normal tissue tolerance, and I'm trying to reduce the risk of potential side effects. The rectum is immediately adjacent to the tumor, and you can have risk of rectal bleeding. The sacral nerves, we've at the dose of 70.2 gray up to with 15 years of follow-up, we're not seeing nerve toxicity, but some of the nerve toxicities can occur many years later. So we're trying to reduce the potential risk for late effects. We currently do not have ways to profile an individual patient's tumor to see what's the correct dose for them. I think those tools will emerge over the next decade. We're trying to collect tissue specimens on patients to try to look and see if we can relate the local control of the tumor to molecular pathways in the tumor. But it's really a way to reduce the potential risk for toxicity.
Sir, for this detailed presentation, I would ask you, do you think that application of hyperfractionation therapy may add to the efficacy of this treatment in skull-base lesions or decrease side effects like in pediatric age group?
Traditionally, larger radiation fractions have been associated with a higher risk of normal tissue injury, particularly nerves, and that's one reason we have to date primarily used fractionated conventional radiation fractions. If you have radiation dose that's so conformal that the dose to the normal structures is low and the dose to the tumor is high, then hypofractionation makes good sense. It's just all about what the adjacent normal tissue is seeing. The issue for many of the tumors on the spinal axis is that the nerves are right there. They're often hard to get out of the high-dose radiation field. And so I think we've been very circumspect about doing it. And again, my colleague Herman Sood had treated a number of patients with other kinds of soft tissue and bone tumors, and I've seen patients who at year 15 they're doing well, and year 16 they have a late nerve injury related to high radiation dose. So I think that is an issue that I think over time we'll get a better sense of that. The Japanese group has used larger fractions, and our next iteration, we're going to increase at least the dose to the tumor per day from 180 to 250 rads per day. I think that we think we can do that safely.
With recurrent disease, are you seeing a change in the pathology at all in the cell types compared to the initial diagnosis?
Most of the time, no. Occasionally, patients will recur with a dedifferentiated chordoma, which is more problematic in the sense it has extremely high rate of metastatic disease. And at least in the patient series that we had reported of 126 patients who were radiated, most of whom it was done in conjunction with surgery. One patient developed a radiation-associated second malignancy, which is kind of in the range of what we would expect. For other adult tumors, the rate of a radiation-associated tumor that's different than the one that's treated is about 0.5% at 15 years. It is dose-related, so it may be higher with chordomas. So at least in that experience, it was about a little bit under 1%, but that's a risk. And if there's anything which the imaging characteristics of a chordoma are usually quite characteristic. So sometimes if a patient has for example, the tumors are quite bright on a signal, have very bright appearance on what's called a T2 weighted MRI. If on the imaging of the recurrence, that is not the case, and they look more solid than one might consider rebiopsy.